Right, so this section before lunch now is some questions that, as I say, you've submitted. And we've got an interesting panel here. I know them. These are apparently my colleagues. This is why life is hard, okay? I'm going to, rather than introduce you and stuff like that, I'm going to go down the panel from Rachel first. Just say who you are and why you think you're on the panel. What's your expertise? And then I'm going to throw some questions into you, okay, to make it really easy. All of them are going to end up with, certainly these four are going to end up with a question right at the end, which you knew about to a degree, you know, and if I was your fairy godmother, and I'm not, but if I was, okay, and I could give you unlimited resources, which is time, money, resources, people, to improve healthcare, whether it's in PH or healthcare generally, over the next 5 years, what would it be? So it's like a wish of something, but so think about that towards the end. So Rachel, just introduce yourself and then I'll start asking some of these questions.
So I'm Rachel Crackett. I'm a nurse specialist in Freeman Hospital in Newcastle. And when I got invited to do this panel, I was told I was an expert. So apparently I am. I've done PH for 24 years, so I suppose. So I think my expertise is initiating treatments and talking about diagnoses.
Carl.
So I'm Carl Harries. I'm also a specialist nurse in pulmonary hypertension. A bit like Rachel, I've been in the job for 23 years, I think, so you're a bit ahead of me. My desire in terms of pulmonary hypertension, I think good access to drugs, develop a cure if we can, but I think that's inevitably not going to happen in the near future. And to continue working with patients and making lives better, because I think one thing for sure you do see with the diagnosis of pulmonary hypertension is somebody who's very sick becomes very well when they're on treatment. And I think that's what I would say.
Good. And it's a special day today, isn't it, Carl?
Sorry?
Is it a special day today?
Well, it's the 9th of August, yeah.
Yeah. Is there anything special about the 9th of August?
Ooh,
we'll leave it till the end. We'll leave it till the end, that one. Okay? Clear your throats. Can you sing Happy Birthday? No, we'll do that later.
Oh, the reason why I'm here, by the way, is because you asked me.
Yeah.
So
Okay. Good. Wendy.
I'm Wendy Gin-Sing. I'm a nurse consultant at the Hammersmith Hospital. I've probably been doing pulmonary hypertension as long as Ian. I've known him for a very long time. Looked after my first IV patient in pulmonary hypertension in 1996. And I've been officially in the role for 25 years. So I share my anniversary with the PHA. And I'm here because I volunteered and said, Sean, would you like me to do anything? And he said, yeah, go on the panel. And then just sent me the questions about 10 minminutes ago.
Yeah, that's good.
So I've only actually read the last one.
You can't make it up then. You can't use AI, can you?
No. But I will say, over the years, I've just seen amazing difference in the treatment of pulmonary hypertension. Set up specialist centres, new drugs, more research, and the future, I think, probably is brighter now than it's ever been.
Good. And Alan, what are you doing here? And who are you?
I think everyone else is busy, which is why I'm here. So my name is Allan Lawrie. I'm a research professor at Imperial College in London. And I guess unlike most people here, I'm not a clinician. I'm a PhD scientist, and I've spent almost as long, about 23, 24 years researching in pulmonary hypertension, trying to understand everything from disease mechanisms to trying to identify drug targets, develop new drugs, all the way through to more recently trying to support early diagnosis, similar to some of the tools that Andy mentioned.
Good. So you're all volunteers. There's no payment for this, you know that, don't you? You're not expecting anything at all? Yeah? No. So, questions. Carl, I'm going to come to you first because you mentioned something really important. Okay, drugs. Okay?
Yeah.
And I want to say something about 5 minutes, and the rest of the panel, if you want to say anything, then do feel free, otherwise I'll move on to another question. About this new drug that's on the horizon, the kid on the block, Sotatercept. You may have heard about it. I'll explain to you where it is in the process of being made available, but Carl, just give me from your perspective what your experience is and why it might be a good thing, a bad thing.
Well, I think it's the new kid on the block, as you said, and it's a new treatment, and it's different from every other drug that we have available to us. Because I'm not going to talk about its mechanism, but it's a disease-modifying drug, and that's important because it's affecting the way that the pulmonary arteries are, I suppose, in the structure. And it seems to be having a really positive effect with patients in terms of how it makes people well. Unfortunately, the access to it is quite limited, and we were in the UK given an early access program, but again, it was to a very specific group of patients, and the access to that program was very short-lived. So there was a very narrow window where we could recruit patients into it. But it is being effective for those people who can get it. And I think the other thing with sotatercept, as it's called, or the drug that shouldn't be named maybe in certain areas, is that it's going to be available to, I think, a very restricted number of patients in the UK. Its cost is going to be tremendous, which is not the problem really. I think it doesn't matter whether it costs £1 or whether it costs £1 million. If it's working, you should get it. Like I said, that was my key thing about getting access to medicines for all patients, where it works for that patient actually, because some drugs don't work for certain people with pulmonary hypertension. But I think it's a new kid on the block, and it's here to stay, I think.
Wendy, I know a large part of your job now is research stuff. And can you add anything sort of more to what Carl said about where it is, how it's being used?
Yeah, and certainly, I mean, we've been the same as Carl. We've had several people in the research programmes that have gone towards the licensing of sotatercept. So we've had patients on therapy for many years now, plus ones that have gone through the early access programme who have been assessing at 3 or 4 months. And I will say it works really well for some people. It works moderately well for others, and it doesn't necessarily work very much for another group of people. We've really got no way at the moment of telling who it's going to work for, although we are looking at sort of proteomics and genomics, sort of, bits that we take blood samples from just about all of our patients every time we see them, and trying to track through if there are signals about who will respond to different drugs. And I think there are some early signals that are coming through, but it's still not at the stage where we can say, you're in this group, we need to give you this drug or that drug. But I think it will come. So sotatercept's good. It's not without side effects, and it doesn't work for everyone.
Okay.
So, but when it does work, it's pretty amazing.
And Rachel, I'm not going to drop this on you. Can you describe what an early access programme is? If not, I can do it. But and with sotatercept, how it's being done?
So sotatercept's been trialled in clinical trials, so people could have access to being in a trial. The problem with clinical trials by drug companies is they're very specific on who can enter those trials. So even though a drug can work in clinical trial, and that's what gets it to license, it doesn't necessarily mean it will work in the real world, because, as I say, the criteria of entering a clinical trial can be quite tight, and we're humans and we vary, and we don't all fit into that little box, so we can't get into trials. So the drug's well on its way to being it is licensed, it's well on its way to being funded. However, what the company did was they offered us, as Carl said, a very short window that we could use something called like a compassionate or an early access programme, where the criteria, if you think the criteria, was 10 millimetres, you had to fit in 1 millimetre in pH to get into that early access programme. So, if you imagine all the different pHs is 10 millimetres long, you had to sit in 1 millimetre in order to get into that early access programme. So we've actually got 7 patients, that's it, at Freeman. That's a very small percentage of our cohort. So it was very difficult, and the timing was tight. And also we had to find resource within the hospital to administer, order, work out how we're going to get those patients that drug. It's an injection, it's not a tablet. So it's a bit like a heparin injection. Most of you probably had those in your time. It's very similar to that. It usually, we're putting it in tummies. I don't know what other people are doing. So it isn't straightforward. It's going to be classed as a complex treatment, because people will have to be trained how to use it, and that unfortunately is resource, and I know where resource will have to come from, and I don't think there'll be any extra resource. So And as Wendy said, it's a very good drug. And out of our 7 people, we've got 4 people that it's made a huge difference to their lives, actually. One especially, couldn't walk the length of the corridor, and he walked nearly 400 metres the last time he came to clinic. So massive, massive difference. But there are 2 or 3 patients where it hasn't made any difference at all, or not that we can notice so far.
Okay.
So I don't think it's the magic, it's not a magic wand, I think. But I think in some patients it will be could be very life-changing.
That's excellent. Allan, I'm going to come to you in a minute because I want you to think about a new drug, how the technology in your work might assess how effective things are rather than just seeing it. So I'm going to ask you to know, just to give you some background to Citaset, because we as an organisation have been involved, it was this week on Tuesday this week with NICE, National Institute of Clinical Excellence. So NICE are now considering Citaset, okay? Just to give context to that, NICE will only consider drugs that have been licensed, and as Rachel said, and Carl and Wendy, it's licensed, it's in use, and globally it's being used in the States, for example. What NICE will do, so it's not does it work or does it not work, NICE have this task, and Carl, you've touched upon this, is the cost of the drug worth society paying for it? That's roughly what NICE do, okay? And we're involved in that process on your behalf. And when we do survey work, and when you get involved and tell us what pH is like, etc., that gives us data that we can say to NICE that, 30 years of treating pH at the moment, we still have too many people who cannot walk to the end of the corridor, whose life is shortened, etc., that there's still new drugs. Just to bear in mind, what does that drug cost look like at the moment? And this is why it's difficult. In the States, it's being sold to individuals through healthcare, if you can afford to pay healthcare insurance, $33,000 per month. Okay?
Per injection.
Per injection. Okay, that's what it's being sold of. Now, so one of the works that needs to be done is not only can we persuade NICE, which is a government body, to say we need access to that. Some of that work is, because it is a good drug, okay? It is a significant, probably the biggest new drug for 15 years. For some people is, can we access it? But we will need to negotiate with the drug company, MSD is a drug company, because there is no way in the UK that drugs at $33,000 per month get anywhere. That process has been started. We will know the outcome from that meeting we were involved in 5 days. So probably by Monday, we'll know the outcome. That outcome will be a negative, okay? And it will always be a negative because how NICE work. It will not be a positive, okay, for the next process. So there'll be later meetings. I'm absolutely certain that we as an organisation, I said in the session before we had the coffee break, we will have to do some fighting to get access to this drug. There's no doubt about it. But it's worth it. And as Carl, Wendy and Rachel have already seen it in some patients, it makes a difference, okay? And if it makes a difference, it's not your problem that you've got a rare disease, okay? Or your loved one's got a rare disease, etc. So there it is. So, Allan, just on the basis of do these drugs make a difference, so the work that you're involved in as a scientist, etc., how, sort of wearable technology or the other stuff, can we use that going forward? A bit like the AI stuff, new stuff, just...
Yeah, I guess, the concept of is a drug working is probably, different people measure that in a different way. Your clinician might assess it by how far you walk down the corridor or how much you breathe into a tube. Ian told me this probably about 20 odd years ago, but it's probably more important to find out how the patient feels. And I think some of the stuff we're doing and is trying to relate that. We all know if you feel well, you're more active, you walk around more and you do more activity and so on. So some of the stuff we're doing is trying to take that, we call it passively sensed data. So that's just when your phone or your wearable is on your wrist and in your pocket, what your daily activity looks like. And I think we've got some pretty good evidence now that actually without forcing people to do more, just going about what they feel like doing, there are some signals in there that actually might give us an earlier read to whether a drug may or may not be working, at least in terms of how the patient feels. And I guess one of the challenges, in my heart, I'm a biologist, so if you ask me how drugs work, I want to see some biological readout for that. But I think there is also pretty good evidence now that actually there's a pretty strong link between just general levels of activity, what our biology, what our inflammation profile looks like, and so on. So I guess we're trying to use that as a surrogate for perhaps needing to go to a hospital or your doctor for a test to see if a drug's working, that you could probably see yourself just by looking at something on your phone or your laptop.
Okay. And think about the work that you're doing at the moment. Have you got any projects coming up, or is there something that, particularly in PH, or wearing wearable devices that might be of interest, or thinking whatever?
Yeah, so I think there's a lot of power in your phone, but I think particularly when you pair a phone with a wearable, whether it's a Fitbit or an Apple Watch or a Garmin or any kind of other wearable, is that combination of data can be used to, I think, help identify patients earlier. So Andy mentioned it in his presentation, and you'll all know because you've all been through it, there's a huge lag between perhaps when you had your first symptom and when you get that diagnosis of pulmonary hypertension. So we have, using similar AI to Andy discussed, we have some tools that we can apply to that passively sensed data that's on your phones that can help to identify someone that might be at risk of developing pulmonary hypertension, to the point where you can then at least have a conversation with your healthcare person, GP or whoever, just to raise the fact that, have you thought I might have pulmonary hypertension or so on. And then I think once you have diagnosis, we're trying to develop some tools to then help you manage your symptoms, or not so much manage your symptoms, but just track how you're doing. So again, it's looking at what we call digital biomarkers, so things you can look at, whether you want to break it down to a simple step count or something slightly more complicated that I guess just makes sense with you in terms of how you're feeling and how you feel on a day-to-day basis about doing stuff that you can just see how you're progressing. And then I think, the last bit we're trying to do is, again, it's using some of the large language models that Andy mentioned, is try to have some gentle coaching. And I was interested this morning in the patient panel just talking about kind of waking up in the morning and not feeling right. And I guess when we try to do this AI coaching, we call it, for promoting activity, one of the things I'm really sensitive about is that our AI models recognize someone who's got pulmonary hypertension versus someone who's not and otherwise healthy, in terms of tuning how we try to motivate people to get up and work. Because I think that, it was in the news just 2 or 3 weeks ago that this 10,000 step thing is a load of rubbish and it came from nowhere. But I think what is important is relating yourself to yourself. So even just on a daily basis, if you add 1 more step or 10 more steps, for you, that's a big percentage change. And I think that's what we're interested in trying to do to help people manage it. So some of you may well get some comms in the future if I get the funding, but we're trying to launch a new app that we can try to do all those kind of 3 aspects to try and help you as much as anyone.
And we've been working with you and others in those sorts of things. So they're the type of things that we'd like to get involved in. I know your colleague, Andy, the Miracle Study, generating reports. We report. So again, the PHA is involved in that, and some people here, and we've recruited to that study and things like that. I'm going to come to the 3 nurses again. Actually, the 3 wise nurses. Have you ever seen the opening scene from Macbeth? The 3 witches on the beach.
We'll get around that, don't worry.
Just because one of the things that Alan's talked about there is about the individual stuff, and I want to just talk about a bit like lifestyle, because we can talk about expensive drugs and things like that, about the importance of lifestyle and setting goals and things that. Wendy, I'll start with you and then Carl and Rachel about those conversations and why, as we heard in the panel about doing things, what sort of wise words would you now be sharing with newly diagnosed people with PH about what you can and can't do, and food and diet and all those, just the basic stuff that makes us all tick? Who wants to start that? Rachel, go on. You look excited at the prospect.
So, one of my things is the difference with PHs and sort of other diseases. There are things in other diseases that you can do to change things. You can lose weight and you can eat healthily and do all those things. And actually it can change your condition, in heart disease, for instance. Whereas in PH, in some ways, whatever you do isn't going to change that. It's not going to go away. We can't modify it. However, I think it's really important that my advice to patients is that you do all those right things as well, because we all should, to keep in good health. And I encourage people, one of my things is about fresh air. I think there's a lot to be said about going outside. And I know in this country, in the winter, it's tricky, but there's something very positive about breathing fresh air. And somebody said, well, I can't go out in the wind because it's, even if you go to your front door and take in 10 breaths and then go back inside, you've had some fresh air. And I think mentally and physically, there's so many positive things about fresh air. So that's one of my things I say to people, try and do something. I'm not going to say too much because obviously the others have to comment. I don't want to steal all the things. But that's my. I mean, there's one of my patients here today, and I'm sure I've said that to you, that you've got to get out and you've got to keep doing. And I think, seeing the sky is really important.
Carl, then just following on what Rachel said about doing stuff, exercise, and just how do you advise them? You said, well, I get dizzy, I get lighter. What would be the advice? And is it safe to do stuff?
Well, I think it is, and I think going back to the original question and bringing in what you said is demystifying the fact that you can't exercise or the fact you can't fly. Which were both brought up by the patient panel this morning, which was really good and encouraging, especially the exercise bit. Going back to the bit of, well, if you're feeling dizzy, well, maybe we should look at why you're feeling dizzy. I think that's something else as well, because it's not always that's a symptom that needs to be managed as well, I think. But I think, the exercise, we know, for example, improves quality of life in patients with pulmonary hypertension. And I think it builds your stamina and it makes you focus on being well, which I think is something that's encourageable. I know, and there's lots of lifestyle issues that we have to address in pulmonary hypertension. And I think that's the challenge in the clinic, if you like, or even on the telephone or on email, in whichever way you get in touch with your specialist teams. But I think there's a lot of positiveness in activity and lifestyle that we don't address.
It's slow build-up, though, isn't it?
It's a slow build-up.
That's the secret.
You can't run marathons.
I think, contrary to popular belief, everybody gets breathless. So if you meet me at 7:30 on a work day at the hospital, I've cycled to work. I'm bloody breathless when I get there. So everybody gets breathless. So being breathless is actually normal, but it's how you manage it and how you build up to it, and knowing your limitations. So to me, it's a slow build-up. Even if you walk 6 steps one day and the next one you do 7 steps, and if you're breathless, it's okay to be breathless. What isn't okay is if you can't speak and you're breathless, because at that point you've gone too far. So the golden rule, I don't know what you tell your patients, is you have to be able to talk and do what you're doing. And if you can't, it's time to stop.
And if you get too lightheaded or you get chest pain, I would say you need to stop. But if you're getting breathless, then you're exercising properly. And that comes down to sort of walking, working, sex, everything else as well. It's actually good to be breathless at times, because then you're exercising your body. I often say to people, we're talking about the Fitbits and how much how many steps you walk. And a lot of people have got them, but just use them as a watch. And so often I'll say to people, especially when they've first been diagnosed, is just look back on the last week and see what your average sort of steps were each day. And if they're like 1,500, then try and build it up this week so they're like 1,600 every day. And then just gradually do that. And, this myth of 10,000 steps, I've tried it, it doesn't work, as you can see. But it's building up on what you're actually doing and being aware of your body and knowing what you're doing. So, so they are very good. Also, I would add into sort of lifestyle and diet is sleep. Is very important as well. So you get good quality sleep. And mine tells me that I don't get good quality sleep any night. But it's being able to use wearables to help motivate yourself as well.
Can I just ask in the audience, who wears a wearable, whether it's a Fitbit, and actually uses it? Yeah, I do.
Lots of recruits.
Yeah, I do. I use it quite a lot. Alan, just because I do want to, this thing about 10,000 steps, and it's said it's rubbish. Can you tell me, is it rubbish? And the reason I ask it, one is less about that, is that sometimes we have research and then somebody comes along and says, that's rubbish research and something. So as a researcher, I want you to justify your salary, okay? But just this thing about it. And then the 3 nurses again, we're going to have a question, it's a more difficult one at the panel this morning about pregnancy. Just want to have that discussion as well, so think about that. So Alan, just think about it. Why is research sometimes disproved by other research? What are you lot going on about?
So my first defence of that is that actually the problem was that there was no research that came up with 10,000 steps. Okay. So that's number one. And I guess all that came out recently, there was a big meta-analysis, so taking in all the literature of all the studies where they looked at step counts in cardiovascular health, and they've basically shown that iteratively increasing by 1,000 steps reduces your risk of cardiovascular events. I think, we're always learning. I mean, research is research. If we knew the answers, we wouldn't do the research. And I think technology develops, knowledge develops over time. So I think we're obviously always learning new things. So I think it's normal for us to think one thing, 1 year, and then the next year we've either got some new technology or some new knowledge or something that helps us develop that. So I think that's how we learn, right? We make mistakes, we do stuff, and we move on. So yeah, I think there's always going to be a kind of learning process and iterative development.
Good. So it's like the evidence was never there, was it?
The evidence was never there for 10,000 steps. I can't even remember. There was a piece in the news article that said actually where it did come from.
Did it not come from a song? Was it not a song there? 10,000?
Yeah,
It was somewhere in Japan, wasn't it?
Yeah, it was an old Japanese study, but I can't remember what. Anyway, it's complete nonsense.
I'm going to go on to pregnancy just to go on to something completely different because it was mentioned, obviously this morning, and it's this time of diagnosis where things are, and all four nurses here, we were at a time when we started in PH pregnancy was absolutely not and things, and the world has changed. And I'm going to go to Carl again first because I know we've worked in Sheffield with the Brompton a little bit with some more difficult patients. So, Carl, what's the position? What would you want to say?
So 22 years ago when I started, or 23 years ago when I started this job, the advice we were giving then is very different to what I say today. And I think the Pulmonary Hypertension Association sort of grew up with pregnancy in that they dared to publish a book on pregnancy and to say that actually you can have children. And that's the myth with pulmonary hypertension. It's not that you can't have children, because that's the wrong word. It is that you should, the wording was you shouldn't. But in today's world of pulmonary hypertension, I think we face the challenge of looking after women who want to have children and do get pregnant, and even though they're counselled on maybe not progressing with the pregnancy, I'm very much supportive of carrying on with that pregnancy, but knowing that there's risks associated with it. And I lead in the pregnancy service in the Brompton, and I can honestly say it's a challenge, but it's a challenge that it usually has, from my experience so far in 23 years, is that we've not lost any mums. Actually, we've been very fortunate, and I think the position is that if you are determined to have a child, then you get in touch with us, so that we can prepare and look after you properly from the beginning. And also to know that there are other options, beyond pregnancy. And I think, there is surrogacy, which is a very expensive process and is another minefield. And also adoption, again, is another option. But it's not very often taken up, the latter. Adoption, you don't see that many people adopting, going through adoption. But overall, I think the approach is positive.
Rachel or Wendy, anything to add?
I just, on the subject of adoption, actually, I have a close family relative who is currently trying to adopt, who does not have any underlying health issues. And actually, they've ceased the process very recently because they found it far too stressful. Because the questions that they ask and how they go into lifestyle and previous life, and people are very, and I don't mean this, but well, there's always adoption. Well, actually, adoption in itself it can be an arduous process, is what I would say. But going back to pregnancy, I think if you really want a child, the way we deal with it in Newcastle is, tell us that's what you're doing. It's the worst thing is if you go away and do it and then turn up 5 months pregnant and in trouble. I think you need to go in with your eyes absolutely wide open, and I think it's not a nice conversation to have because it is risky. We have had quite a bit of success, but not without it's a rocky road, is what I would say.
Because Wendy, the planning pregnancy, if you want to, and have these conversations, thinking about some of the drugs we use and why that could be a problem. Just want to talk a bit about that.
Yeah, I think we do things at Imperial same as everybody else does, and we're very fortunate that we've got Queen Charlotte's Hospital right next to us. So we rely on them a lot for gynecology and obstetric help as well. So we run a high-risk pregnancy clinic. And the consultants there know pulmonary hypertension very well because they're the ones that tend to deliver our ladies. And so anybody considering a pregnancy will go to the clinic. You know, they will have spoken to us, or sometimes it's a joint clinic where they'll talk about the risks. And then it's up to the individual to make the decision. The one thing I will say is that there's no way of predicting how people will react. So sometimes you have people with quite severe pulmonary hypertension that get pregnant and actually don't have too many problems. And then other people whose pulmonary hypertension is very stable, who then run into problems very quickly. And as Ian was saying, it's really important that we plan pregnancies if people are going to have them as much as possible, and that they let us know, because drugs like endothelin receptor antagonists, things ambrisentan, macitentan, bosentan, can also potentially cause birth defects, so they shouldn't be taken in the first 12 weeks. So if our ladies come to us and they're either thinking getting pregnant, we might change their drug therapies so that they're not on one that's going to cause problems, or as soon as they're pregnant, then we'll take them off the ERA. But I think all of us probably didn't have any grey hairs when we first started doing this. And I think a pregnancy is so carefully managed in the hospital. We have frequent MDT meetings with neonatologists, anaesthetists, the obstetric people, pulmonary hypertension, just about everybody else. And sometimes 30 people in a room planning on the pregnancy. And then, in our centre, it tends to be one of our consultants, and one of us will go into elective caesareans, is what we tend to like doing, but we'll all be there. So everything is very, very augmented. So we'll get people delivered on a day at a time when everybody's going to be there that needs to be there, and then they're very closely monitored in intensive care afterwards. Because it's not just the pregnancy, it's the return to normal circulation after the baby's been born can sometimes be a bit tricky when you get all that extra blood volume going back into the heart. So it can be done, but we just need to very closely monitor people. And we get quite a few people that come to us because they've developed pulmonary hypertension in pregnancy, or they started collapsing whilst they're pregnant, because they probably had it before and it's made them worse.
It'd be interesting, wouldn't it, Alan, to some of the implantable devices in pregnancy to understand some of that physiology that it would be, because there's been no studies like that done, has there?
No, not that I'm aware of. I think there's relatively few patients in the UK that have implanted devices, but it'd definitely be worth.
It's interesting, Cole's comment about the PHA does have a book on pH and pregnancy, and it was about 5 years ago. I think some of you were involved in the draft, and I remember when we published it, and it's used sort of globally, and you go to conferences, and it's the one publication that myself has chaired the PHA when I've been to things like ERS, European Respiratory Society. I come across highly opinionated consultants from other places who think we did something terrible by giving you information that really was not very good. And I'd do it again and again. And that our job is to give you information, not to. I think sometimes healthcare and medics, not all medics, can be risk averse. And the easiest thing always is to say no. But that's not true anymore. So that's an interesting point. I'm going to sort of give an opportunity.
Say something though at one pregnancy about the intensity of care that women will go through, though. I think that's really important, and how careful we are in the UK with patients who the ladies that get pregnant with pulmonary hypertension, I should say. It's 2 weekly visits to the hospital with the pregnancy teams. So you've got your consultant in obstetrics, you've got your women's physicians, and you've also got the PH and cardiologists. It's a massive input to make sure that you stay well, and I think that's encouraging in this day and age.
And sometimes we'll admit people to the hospital for a month before they are due to deliver, so we can keep a really close eye on them, and just in case they go into early labour, especially if they live a long distance away. Our Welsh patients tend to come and live with us for a little while. And quite luckily, we've got a nice little room they can stay in. But
have you?
Well, not us. Queen Charlotte's next door have. Yeah.
Can I use it? Want to come down? Okay. So what I'm going to do for the sake of time, I'm going to ask 3 of you about the fairy godmother question now, and then the others I'm going to ask you in the session after lunch the same question. So I'm going to ask Rachel Wendy, and Andy, because you still sat there, if I had a magic wand and you could do whatever you wanted, what would you change, either in healthcare per se or in PH? You could have any resources. Where would you spend that time and money and resources? Who's brave enough to go first? Wendy.
So I've got two things. One is the big thing, is joining up the NHS. It's so frustrating, both from a nursing point of view and from a personal point of view, to not be able to access blood results that have been done in a GP surgery, to chase after somebody else. Luckily, a lot of the imaging scans can now be sort of sent through. But just, I personally have got to go for a pre-op on Monday, but I've had 3 pre-ops already this year, but they were done at a different hospital. So now I've got to go again and see another person. I've had to fill in all the forms again. And yet the 2 hospitals are only within a few miles of each other. Why people just don't talk. And from a nursing point of view, chasing up results, investigations, finding out exactly what somebody means when they said, I had something to do with my bowels, but I'm not quite sure, and I didn't know if it bled or what treatment I had. So things that will impact quite a lot on the kind of treatment that we give. So that would be my first thing, for everything to be joined up and the patients to have access to it. When I go over and have echoes done, they refuse to give me the report. They can only go to the doctor. That drives me mad. So I will send anybody anything. And my second one is to have personalised medicine, to be able to have something, a bit like the old Star Trek thing, except with the bit that just scans them, if you can all remember Star Trek, and sort of say, oh yeah, you've got this wrong. I'd love something like that. Probably we'll get there with some blood tests so that we can target the drugs that we give to people. So you don't give drugs that are a high enough dose, it's going to give them side effects, or drugs that are going to be ineffective. And I think that would be better experience for patients as well as spending in the NHS.
Yeah.
So those are my 2. And can I have them done by tomorrow, please?
Yeah. Andy. Star Trek, can you get that sorted?
Mine was actually going to be exactly the same as yours, honestly. I really do think that. I think, wasn't it Tony Blair who said he was going to invest in getting the whole of the NHS to be one unit? Is absolutely crazy that we can't join things up better. But hopefully that will improve. So I think in replace of that, I would say it's about independent of people's experience or what experience they've got, having a tool available to them that you can use. So I think, for instance, say with these large language models that are available, ChatGPT and stuff, if you just spend some time, if you have got some symptoms, you can spend some time talking to it. As long as you don't, go too crazy believing everything, you can learn a lot about all sorts, and they're only going to get better. So from a patient perspective, I think you really can. I suppose you're told not to Google, aren't you? But with a pinch of salt, and then obviously you've got reputable resources as well with the PHA and everything to come to. And I think that works as well at the hospitals. If you're a local doctor who sees a broad range of different conditions, then to have the different degree of AI experience available to them, that's important. And I think it's the GP level, isn't it, where a lot of patients you go multiple times, some patients have been 4 times or something, and it was David, wasn't it, who did the study of Kylie in Sheffield, and yes. GSK did a study where they tried to look at the healthcare usage, and they really only identified that if you went to the GP many times. Oh, it was Allan, it was you who did it, sorry. That was the main thing, wasn't it, that it was the healthcare utilisation. And whether now with these language models, you could find something more, a clearer pattern now. I don't know what you think of that, actually.
No, I completely agree. I mean, it's kind of what we're trying to do with it. We're trying to marry up the app data with the healthcare data to do exactly that. But yeah.
Rachel, I'm going to come to you as the last one. Just before you do it, just a bit more thinking time. I'm reminded, as we talked about not joined up thinking, Wendy, you said lots of visits and stuff like that. I saw a lady in clinic on Monday, and it was mentioned this morning somebody got sleep apnea, and she was a big lass and really nice, but she had a local sleep study in January because we'd asked the local team to do it. I saw her in clinic and said, had you had any results? You know, what's happened? She said, I've had it. And she was a practice nurse in a GP practice. And I said, well, it's really odd that you've not had the results and stuff like that. And she said, well, let me just have a look on my app, see where the process is. And the results had been sent to the GP 4 weeks afterwards, and she got sleep apnea. But for 6 months, she'd been walking about with a very treatable condition. And it's this joined up thinking, it's this joined up. We all work in the NHS. The biggest frustration is communication. Okay, this stuff that Andy showed is really important, crucially important, but it's no good if it can't go where it should go to, and that's a really important thing. So, up the revolution. But
so mine's communication based, but it's a bit more basic. So. This actually came from a sentence that my husband's cousin said to my mother-in-law, and his words were, do you know what, when people are in hospital, everybody should have a Rachel, which was a lovely compliment to me. So he was in with heart disease, he had an abnormal rhythm, and I went to see him, you know, every day. He was in our hospital, not under my jurisdiction at all. I went to see him as a visitor, but he was telling me what he thought was wrong with him, and I, with his permission, spoke to his consultant, and then I went back to him and drew him some nice pictures of his heart and how your electrical impulses work, and did all of this. And every time he got some, and he was in hospital 4 weeks, so he had a few problems. And every time this happened, I would speak, or I would be on the ward round with him, with the consultant, as his advocate, not as a nurse. And then afterwards, I would explain what the consultant had said. And it wasn't until he went home and actually said to my mother-in-law, he said, everybody needs a Rachel when they're in hospital. So it got me thinking, if you magic wand, I think, you know, we have specialist nurses in PH because PH is very rare and it's very serious, and that's why we have specialist nurses. And we have them in other specialties, but there's no atrial fibrillation nurse in our trust. There are right heart failure nurses, but I think every condition or every ward round should have somebody with them on that ward round to then go back and explain what that doctor said to him. And that isn't possible. I mean, we're lucky in a way in PH that we do have that resource. But he had nobody really support. I mean, there were the ward nurses, but the ward nurses haven't got time to be on ward rounds anymore. You'll all know that, don't you? They get the handover, but they're not there, so they don't know exactly what was said. So if you could wave a magic wand for me, we would have more people like us, but in other specialties. So people have got somebody to ask about what that consultant said.
Excellent, good just to think. It'd be really good. I mean, it follows on, doesn't it, Andy, with like your colleague, I forget his name, the miracle study. It'd be really good post ward rounds and discussions in clinic if a similar sort of process, right? And before you went, there was a printout, a generative AI printout that said, this is what we've discussed in language that's understandable. I'm desperate at the Hallamshire to do our clinical letters to you, the patient, not to a GP who probably doesn't read it. And you should be able to understand it, and everybody else, because the other thing that would be far better is for healthcare professionals to understand what you think rather than we want you to understand what we think is there. So it'd be really good if there's some joint thinking.
There is, though, a technology in AI that already does that. So in your consultation that you have with, say, me, you can have software that will actually record what you're doing or saying, and then it will produce a letter of that consultation. I've not seen it, but I know it exists.
Yeah.
And our trust are trialling AI letters. So basically, well, they're trying to get people to volunteer for it, and I'm sitting on the fence because I don't understand technology. Need to talk to them. But yeah, I mean, I think things like that will happen, and they'll put it in better language. And also, you could have potentially like two options. One that goes to your local doctors or your GP to sort of say, actually, you need to do this, this, and this. And one goes to patients to say, we're asking them to do this and this because of whatever. But it's coming there.
The problem with other healthcare professionals, though, they don't understand pulmonary hypertension either, actually. So that's another thing we need to address, I think, in the world of pulmonary hypertension.